Parker is and on Zoom this week, and I'm honored to be introducing today's meeting. So I told Alon that I would try to keep the ship sailing in the right direction, but made no promises. But to help me feel confident, I did look up some instructions on bell ringing. I hope I did it right, but you need the etiquette is you need enough force so that you get everybody's attention, but not too much to ring everybody's eardrums. But I did look up the history of the bell, which I thought was a little bit interesting. Does everyone know what the history of the bell? Okay, so while the use of the bell has never actually been mandated, most Rotary clubs ring a bell to call the meeting to order or to adjourn the meeting. Both bells and gavels have a long association with Robert's Rules of Order. Early Rotary leaders adopted Robert's Rules as a way to govern meetings. And one of the earliest published stories about using the bell at Rotary is from a 1915 ladies' night meeting in Kansas City, Missouri. The sign commanded attendants sit down when the bell rings. By 1919, the Kansas City Club had acquired a large bell, which they referred to as the gavel, which was fashioned out of a horse-drawn streetcar gong and run with a large wooden mallet made from wood of a German bayonet. And then in 1922, the Rotary Club of London presented a bell to the Rotary Club of New York City. The bell was a prize over a long-running attendance contest between the two clubs. In 1923, a decorative bell was advertised in the Rotarian for use by clubs called the Rotary Bell number 29. This bell was marketed for use at Rotary meetings as a unique table ornament, a slightly prettier and infinitely more agreeable than the harsh gavel. So there you go. And now I will hand it to Sally Gaskell for our reflection.
Thanks, Teresa. It's great to have you at the podium today. So I might be talking about baseball because obviously it's March. We're in the throes of spring training, and really cool, this thing that happens once every 3 years or so called the World Baseball Classic is deep in process. So it's such a great tournament, particularly the games between the Latin American countries and those in East Asia. You understand how important it is for these professional baseball players, particularly those who have left their home countries to play in the United States, to pursue their dreams of playing baseball, but also for those American players who are representing their heritage by playing for teams like Israel or Italy. It's so cool for them to participate in a tournament like this. Also the fans, Taiwan, Japan, Korea, Venezuela, Puerto Rico, Mexico, the Dominican Republic are just so fun to watch. But I'm not going to talk about baseball. I'm here to talk about the Rotary Book Club. We began the Rotary Book Club during the pandemic online, and we're now meeting both in person with a Zoom option. We meet once every 3 months. Everyone is welcome. You don't have to come every time. We do have a core group of readers, but others are always welcome. We decided at the beginning to focus on Indiana as our theme. And so we've read books, both fiction and nonfiction, that are set in Indiana, like The Eloquent Zori by Laird Hunt. We read books about Indiana, like Jim Madison's The Ku Klux Klan in the Heartland. We also read Lulu Miller's fascinating book called Fish Don't Exist, about the infamous David Starr Jordan. Or we simply read books by Hoosier authors like Kurt Vonnegut. Early on, we read William Cooke's illuminating and heartbreaking book about the opioid crisis in Austin, Indiana, just an hour's drive from Bloomington. And full circle, we get to hear from the author today, thanks to Judy Schroeder. Our next book for our next meeting is by local celebrity author Charlotte Zitlow. Now, and it's a fabulous book. Natalie and I sent out a note to all of you yesterday, all Rotarians, all 140 of you, that the book club meets tomorrow night at my house at 7 p.m. Turns out I jumped the gun. It's actually next month. Third Wednesday, April 19th, 7 p.m. So you've got a whole extra month to go out to Morgenstern's or the Book Corner and buy Charlotte's book and read it. It's really wonderful. So in conclusion, I think that reading is a solitary act that brings us all together. It educates and enlightens. I'm proud that we have a Rotary Book Club and invite you all to join with us. Thanks.
Thank you, Sally. For our birthdays this week, we have Rex Hillary on March 13th and Scott Shackelford is March 16th. Happy birthday to both of you. Member anniversaries, Jim Capshaw, 5 years. Sandy Keller, 6 years. And Jeff Baldwin, 9 years. So congratulations to all of you. And to introduce our guest, we have Joy Harder.
Good afternoon, everyone. We have 3 amazing guests today. And I'd like to start by introducing the youngest of our guests. Her name is Lucy Deckard, and she is the daughter of Trent and Kyla. And we're happy to have her. Lucy is a very important 2nd grader, so thank you for being here, Lucy. Liz Feidel has 2 guests, Janet Tippin and Vanessa McClary, and we're very happy to have both of you with us this afternoon. And I didn't make you stand like we normally do, but nonetheless, you are welcomed and please come again. Thanks.
Michael, do we have any guests on Zoom?
Alas, we do not have any amazing guests, just amazing Rotarians, except for our speaker, which will be later introduced. So that's all.
All right. Well, we have some club updates. We need some district grant ideas. So far, we have 1 response. Thank you to Connie Shakalis for that. So please be sure to send your ideas. And if you know any local partnering organizations that would be interested to submit a grant proposal, you can point them to the announcement on the Bloomington Rotary Club website. If there's any questions, please send a note to Jeff McKim, Natalie Blaze, or Alon. And we have a habitat build update. So we're getting close to our 2 volunteer days on March 18th and then next week, March 25th. So we have the quite a few spaces still available. We especially need people this Saturday afternoon and people to bring lunch. So if you want to see after the meeting, you can, we'll just flag us down and we'll get you signed up if you need help getting signed up. So I will now, we have a few minutes for happy dollars. So anyone have happy dollars?
The room camera is muted.
2 guests today, Vanessa and Janet. Thank you both for coming. I have $5 today. Am I echoing in here? Because Charlotte and I are dressed. You're wearing the right color. Okay. And I'm just happy to be here in person. Thank you.
Any happy dollars on Zoom?
I'm going to jump in and say hello to everybody. I'm here in New York, and it's absolutely fabulous to be part of the Rotary meeting online. How absolutely amazing it is to be experiencing it from this perspective. And I want to just put in $20, happy dollars, in celebration of all of the musical theater kids that did their fabulous performance in New York last night and yesterday afternoon. It was really amazing.
I give $5 in honor of our speaker today. I don't know him, but I read a lot about the heroic medical effort to save hundreds of people in Austin, Indiana.
Wonderful. Okay, well, thank you, everyone. And I will just make some acknowledgements here. So first, Joy Harder, thank you for greeting, introductions, and also making those introductions, Joy. Zoom host, Michael Shermis, Reflection, Sally Gaskill, reporter, Marilyn Wood, camera mic operator is Kyla Cox-Deckard, and Zoom audio producer, Tyler Martin Nichols. So I will now turn it over to Judy Schroeder, who will introduce our speaker.
Good morning or afternoon. Can you hear me? Where should I, there, now I found the right place. All right, compassion, courage, and conviction. Those are 3 words that describe Dr. Will Cooke. He's joining us on Zoom because it's hard for a busy physician to set aside 2 hours to drive for a 20-minute speech. Thank you. Upon graduating from the School of Medicine, Dr. Cooke decided to become a primary care physician. When he opened his practice in tiny Austin, Indiana, just north of Louisville off I-65, it had not had a doctor since the 1970s. In 2015, Austin became the center of an opioid-fueled outbreak of HIV and hepatitis C. Dr. Cooke considered it the canary in the coal mine of what is of this new public health menace. When the headlines came, state agencies zoomed in, swooped in to help. And when the cameras left, so did they. But Dr. Cooke stayed on, convinced that the answers had to come organically from within the community. For his efforts, the American Academy of Family Care Physicians gave him its Family Care Physician of the Year award. When our book group talked about this, some of our members, people like Glenda Murray and Liz Feidel and shared, Kay Leach, who's up there on Zoom, shared their experiences with public health. And we agreed that we would do our utmost to get Dr. Cooke to speak to the entire club. Thank you so much, Dr. Cooke, for joining us.
All right, thank you so much for that beautiful introduction and the invitation. I'm honored to be here, and I'm honored that you all took the time to read my book. I'll skip a lot of my background because a lot of that's in the book, and just kind of go straight to, the reason that I titled it Canary in the Coal Mine, as was mentioned, is I believe that what happened in Austin is the canary in the coal mine that should be warning us of what's going on. As you know, coal miners would bring canaries down into the coal mines with them to warn them of toxic conditions that may exist there that would harm them. And if they didn't pay attention, they could die. They could be harmed. And what I believe is that there are toxic conditions that exist in our communities that are harming people. And if we don't pay attention to those, we're going to continue to see those harms, occur. And it doesn't just harm those individuals, it harms the entire community. I'm going to share my screen if I can. See if I can do this. All right, can you see that okay? So we have seen a decrease in our life expectancy in the United States. In general, each year life expectancy has increased until the last, few years, starting, around 2016 or so, we started seeing a decrease in life expectancy. And if you compare that to the developed world, you can see that we've actually fallen off dramatically. If you put together how much we invest in healthcare, which is a tremendous amount of resources, time, money. When you go to medical school, I was overwhelmed, just marveled at, what we're able to do with technology. And we have that here in the United States. There's no place on earth, that's better at keeping sick people alive than the United States. If you're sick, it's a wonderful place to be because you're going to have the best of the best to keep you alive. But something's happening with our life expectancy that shows that that's not enough. It's not enough to just keep sick people alive. We really need to figure out what these toxic conditions are that exist that's harming people to the point where even though we're good at keeping sick people alive, we're not good at keeping healthy people alive. And if you think about it, if you're just looking at the amount of life a person has access to, it's better to be born somewhere else than the United States. Now that's a dramatic and terrible thing to say, but if you're born in another developed part of the world, their life expectancy outshines ours significantly. Now, why is that? And we can go into what I put in the book here. This is a combination of Maslow's hierarchy of needs with adverse childhood experiences. And when you put those two things together, what becomes evident is that there's basically two trajectories that someone can go in life. They can move upward towards health, wellness, prosperity, or they can spiral down towards early disease and early death. On the upward trajectory, if you're familiar with Maslow's hierarchy of needs, you'll remember that once our basic human needs are met and our safety needs are met, then we can move up to the need of a sense of belonging, and then esteem, where we have esteem for ourselves and esteem for others in our communities, and joining wonderful civic groups like the Rotary Club. Move on to cognitive opportunities, book clubs, going to college, and then moving on to appreciate the arts. As was mentioned earlier about musical theater and books and poetry and all of that, and then moving up to self-actualization and transcendence. And that's what we want for all of our own lives, our children's lives, and what we really want for the lives of the children growing up in our communities as well. But unfortunately, what often happens, and what happened here in Austin, is that a child's born into generational trauma where they're behind, not based on any choice that they made, but they're behind based on the social circumstance that they were born into. If you're familiar with the original definition of the American dream, basically it meant that people have the opportunity to succeed in life regardless of their circumstance at birth. Well, if you look at certain areas of the country that has concentrated poverty and disadvantaged communities, you can see that even though they didn't choose where to be born, where they were born and what circumstances they were born into really set their life in a certain direction. And, you know, when you're born into that generational trauma, you have adverse social conditions that lead to toxic stress, and those ACEs, the adverse childhood experiences, that leads to physical damage to the brain where there's disruption of the neural development. And then that impacts several key areas of the brain that factor into rational decision making, where people aren't thinking through the decisions that they're making. They're just kind of reacting to it. And oftentimes those kids are identified as ADHD. You see the rise in ADHD over the last few decades, and that speaks towards this, that there's actual damage that happens in children's brains when they're raised under adverse childhood experiences. Memory areas where it's harder for them to learn and to remember things. And then those deeper areas where their basic human and safety needs aren't being met. And so they seek out those dopamine releases that normally occur when your basic human and safety needs are met in other areas. And that's often risky behaviors, which leads to early disease, disability, social problems, and far too often early death. And this occurs in really any medical condition that you can look at. This is a slide that's really showing social, something that you wouldn't think your social circumstances would factor into where you're born. But cervical cancer, it was the leading cause of death in women in the 1800s. But with screening and preventative care, no woman should ever die of cervical cancer. Yet we can't get down to zero. There's something that's holding this graft up, in that invisible area. There is a form of violence. It's not physical, direct, visible violence. It's invisible. We can't see it, but it lives within our culture and the structure of the places that people are born into. Oftentimes we blame, someone for what's happened to them because they made poor decisions in life. But again, people don't choose where they're born. People don't choose what social circumstances they're born into, and that often leads to these diseases. You can look at it as an iceberg. You can see someone's health on the surface, but we don't see all those underlying issues that factor into that individual's health, which then factors into the larger community's health as well. I like this graph because it really demonstrates how effort might be extreme in some circumstances. Somebody might be trying really, really hard to do well in life, but they're pushing their health hazards up a gradient. And we don't necessarily see that gradient because, again, it's invisible. But things like poverty, housing, a livable wage, access to your basic human and safety needs, lifelong learning, thriving outdoor spaces or the lack of those spaces, sense of community, all of these factors cause this gradient to be steeper and steeper. And somebody might be trying really hard to do well in life, but there's all these factors that are pitted against them. Again, oftentimes based on where they're born and what social circumstances they're born into, which is not a choice that they made in the first place. So what I believe is that somebody's health outcomes factor, the factors of those health outcomes, depend on three areas: having their basic human and safety needs met, looking at their social, economic circumstances and opportunities, again, that they were born into oftentimes, And then the access to resources and healthy choices, because people can only make choices from options available to them. It's a very simple statement, seems very obvious, but we don't often consider that when we're looking at someone else's health or where they're at in life. So I'm going to say it again. People can only make choices from options available to them. If you don't have transportation, how do you get to school, jobs, the clinic, pharmacy to pick up your prescriptions? If you don't have access to humane housing, what does that child do? So to me, if someone's basic human and safety needs are met, their social economic circumstances and opportunities are healthy, and they have access to resources and healthy choices, then that person's health and prosperity depends on their choices. But if somebody doesn't have these three things established in their life in a healthy way, then that becomes our responsibility to step in and make sure that that child grows up with their basic human and safety needs met, their social circumstances and opportunities met, their access to resources and healthy choices met. So what are the vital community factors that prosper, a person's health and wellness? The Surgeon General's report on economic health and prosperity identified 7. And this comes out of 3 decades or more of established research looking into what it is that grows a healthy person and allows a community to prosper economically as well. Again, an individual's health and wellness isn't just affecting that individual, it affects the entire community. Because unless you have healthy people living in the community that is prospering, seeking out those higher needs that Maslow talked about, that are often benefiting the community, it affects everyone. So the studies really point to these 7, and you're going to hear me repeat this over and over again because it's important, and I hope you can remember it as well. But I do want to say that to me, healthcare needs to be redefined as these 7 things. We know from decades of research that these 7 things foster health and wellness and prosperity. So if we're really looking at what extends our life expectancy, decreases disease and death, it's these 7 things. It's not what I do in this medical office here. Oftentimes people come to me because they're experiencing symptoms of a disease, disability that they've already developed. And then at that point, I'm just trying to help them live with that disease or disability. We love it when people come in for preventative care, because then we can start addressing these things in a way that may prevent disability and disease, but it's a waiting game. I'm here in the clinic waiting for people to come to me. What we need to do is get out into the community, partner with groups like the Rotary Club, the health departments, churches, other community organizations to make sure that every child born in our community has access to these 7 vital community factors. And what they are is, again, basic human and safety needs met, access to lifelong learning, access to a livable wage, humane housing, reliable transportation, a thriving natural world, safe, well-lit paths where people can walk along to get to places that they need to go, and areas where people can congregate and get to know each other and have that, again, sense of community, and get outside and just exercise. We know that it takes about 150 to 300 minutes per week of moderate to vigorous exercise to decrease someone's all-cause mortality. Again, these factors decrease the risk for everything. So 150 to 300 minutes of getting outside and just going for a bike ride, going for a walk, decreases someone's chances of dying significantly. We're talking 30 to 40% reduction in mortality by doing that. And the thing that pulls everything together, and you all know this because you all meet and get this sense together, is that sense of belonging and that civic muscle. And civic muscle basically is believing that your plight matters to other people. That if you speak up and say, I'm struggling because fill in the blank, someone is going to hear you and try to step in to help with that fill in the blank, whatever that might be. Part of that is just allowing other people to know that it's okay to not be okay. Oftentimes we don't allow people to tell us that they're struggling, that they're dealing with something, that they don't have food, they don't have a safe place to live, they don't have transportation. These are sometimes barriers to people asking for help because they don't want to be viewed, as people in those circumstances are often viewed and ridiculed and worse sometimes. Growing up, I grew up in a poor home. My mom and dad did better for us than their parents did for them. My mom oftentimes found herself growing up as basically a squatter right on the Ohio River. Her dad was an alcoholic. Her mom was addicted to benzos. From what I can understand, they had a fairly open relationship, if you know what that means. And there was a lot of fighting because of that. He worked as a carpenter on and off. So sometimes he had an income and oftentimes he didn't. So they would just find a place to live. And she describes these really terrible living conditions. And sometimes they would be found out by whoever owned some shack. And they would have to, grab, whatever belongings they could grab and, scurry under the cover of night to find another place to live for a little bit. My mom and my dad met when she was 14. They got married at 16. She dropped out of high school, actually, but at 16, she had gone further in school than anyone else in her family for generations. They moved to a military base, and that structure and support and just having their needs met, and again, that sense of community and belonging and finding mentors, people that would invest in them, allowed them to gain access to a better life for them than they gave to my brother and me growing up. But it was still challenging going to school initially. I remember my teachers telling me that I needed to try harder. I didn't know what that meant at the time. They told me that I had a lot of potential, but I needed to try harder. But nobody told me what trying harder meant. I thought I was trying hard. I really wanted to do well. I was trying to do well, but my effort wasn't paying off with results. I did end up getting accepted to a local community college, and there I met some students from a higher social economic class, and I joined their study groups, and I learned how to study for the first time in my life. And I learned how to take notes, how to prepare for an exam, how to get enough sleep the night before the exam, and I started doing better. My effort started mattering because I had the resources that I needed in order for my effort to result in good results. And I think about that when I'm working with, my patients. Again, sometimes just trying harder isn't the answer. This graphic here, I can go back to it. This one Sometimes trying harder isn't the problem. That person might be trying really hard. It might be that they don't have the tools, resources, the access to healthy choices. Maybe their basic human and safety needs aren't met. So I keep this broken off piece of lawnmower cord in my office to remind me. One day I was trying to start my lawnmower, and my effort wasn't the problem. I pulled on that thing long enough and hard enough that I broke the lawnmower cord. If somebody's trying really hard, they might just, figuratively speaking, break their lawnmower cord and give up. We got to get to them before they give up. That learned helplessness sets in at some point, and then it becomes very difficult to change the trajectory of that individual's life. How this factors into Austin, in 2011, well, actually, I opened my practice there here in 2004, and I immediately, noticed that there were, pretty significant toxic conditions that existed. People really struggled with life, generational poverty, access to healthy choices. This is a food desert. People don't have access to a farmer's market or even a grocery store. There's not a grocery store here in Austin. And a lot of people walk. Maybe a quarter of the population either doesn't have a car or shares a car with another family. And so they depend on biking somewhere or walking somewhere, and not having, that access is toxic. It leads to, early disability and disease and death. And so I saw these things and was really trying desperately to get help to come to Austin, because I knew as a physician, there was just so much that I could do, but there was a lot of things that I couldn't do, but there were resources out there if we could find them and bring them. Nothing happened. In 2011, we started seeing an increase in injection drug use in the community. We knew this because we started seeing soft tissue infections with abscesses, sepsis, endocarditis, an infection on the heart from bacteria being introduced into the bloodstream, traveling to the heart and growing on the heart, spinal infections. So we knew that people were injecting in the community, and they must have been reusing their syringes over and over and over again, because if you use a sterile syringe each time, you don't inject bacteria under the skin into the bloodstream to cause these infections. Then we started seeing an increase in hepatitis C. Hepatitis C is the precursor to HIV. It's spread the same way. And so we knew something bad was happening in the community. This was so dramatic that in 2012, there was a Reuters article released nationally that identified Austin, Indiana as a place in need, in desperate need. There was an increase in overdose deaths and all these soft tissue infections, heart infections, spinal infections. And they knew Opana was at the heart of this. But again, no help came. This shows the hepatitis C data over the years leading up to the HIV outbreak. And Austin, Scott County ranked near the bottom of the state year after year. And this led to the Indiana Department of Health releasing a report saying that there is an impending HIV outbreak right around the corner because of the increased injection drug use. And there needed to be harm reduction strategies implemented, or there would be an HIV outbreak. Those harm reduction, strategies, include access to addiction services, having, people get better housing and out of those environments, but it also includes things like syringe service programs so that people aren't reusing these syringes over and over again, leading to these infections and diseases that they might be spreading, like hepatitis C. But again, no help came, nothing changed. There really wasn't any testing, surveillance going on in the community. And so between 2011 and 2014, HIV was spreading in the community, unknown to the health department, to the health community. And it wasn't until right at the end of 2014, leading into the early parts of 2015, that we did discover the HIV outbreak. But by that point, you can see this blue line is the people contracting HIV. The red line is the testing, is the diagnosing of people with HIV. And there's this gap here that led to increased spread, through the community. And again, people were sharing syringes, reusing syringes. And so when they share the syringes, they have hepatitis C or HIV, that person they're sharing with is basically injecting virus directly into their bloodstream. But we did end up, Governor Pence allowed a syringe service program to open. I was committed to make sure as a family physician that whatever the community's needs were, I would make sure that we had the resources for that. I didn't want to see people having to travel. I was the only doctor. We didn't have an infectious disease doctor here. So I worked with a nonprofit organization in the state to develop an HIV clinic right here in my clinic. Went on to get certified in HIV and then board certified in addiction medicine as well. So we could offer that service locally. But it was a significant harm to the community, but also to the state. The number of people diagnosed with HIV just in Scott County that year, it represented a third of all the new cases of HIV in the entire state. And it increased our HIV cases in the state by 20%. This is a town of 4,300 people, a county of 26,000. Little things can lead to big issues for the entire community if they're not addressed, if they're not noticed. Again, those invisible factors can lead to great harm within the community. One of the things that I'm really proud of accomplishing during the HIV outbreak was to develop what's called a recovery-oriented system of care within our community. And basically that puts the person in need in the middle. And instead of the agencies fighting each other for services for that patient, or thinking they know what the person needs, we asked individuals who were injecting drugs, who were living on the street, who were struggling, we asked them how we could help instead of telling them how we could help. It's a subtle difference in the wording, but it's everything to the person in need. Instead of telling them how we could help, we asked them how we could help. And we tried to figure out, based on their responses, them as basically the leaders and us as the responders to those needs, what it would look like for people to have access to recovery in the community, and hopefully that step up into health, wellness, and prosperity. This model developed a large group of people who entered into recovery that went on to get their recovery certification, their peer recovery certification, and eventually opened a recovery community organization, a nonprofit organization that is made up of people in recovery. So people who were injecting drugs just a few years ago are now leading as a nonprofit organization within the community to help connect people who are still living on the street, who are still injecting drugs, to services to help them. We didn't have that just a few years ago. One of the things that I like to highlight is that a syringe service program is a place that gives us access. Peer recovery coaches are coaches who can give us access as healthcare providers, as civic organizations, to people that we may not have access to otherwise. If you're injecting drugs living on the street, oftentimes you don't want to be seen, heard. You don't want to be noticed. You don't want people to know that you're injecting drugs. And so for us as healthcare providers to gain access to somebody in that situation who might want help, but just is afraid to ask for help, a program like this offers that opportunity because it partners a syringe service program with peer recovery coaches, therapists, addiction services, access to a physician like myself. And what we saw here in Scott County is that as the syringe service program went on month after month, the number of people who enrolled in substance abuse disorder treatment increased month after month. And so that access led to people entering into recovery for substance use disorder. Also, the number of syringes that were being distributed started to fall off here as well because there were fewer people injecting, and the number of people being diagnosed with HIV plummeted. We were told that people who inject drugs were not going to take their medicine. They were not willing to be responsible for their own health or the health of the community. But we found was that they were willing to take their medicine if they were approached in a way that was respectful. And we have one of the highest viral suppression rates in the state. And you can see the people who were disposing of syringe safely before the syringe service program opened was only 18%, but after it opened, 86%, and the people living with HIV went up to 98%. So people are willing to take responsibility for their own health and wellness if given the opportunity. I really want to answer your all's questions and open it up to that. So I hope we have an opportunity to hear from the audience, people on Zoom, to maybe talk through some of these issues a little bit more.
Well, thank you, Dr. Cooke. This has been a wonderful presentation. Yes, we do have some time for some questions.
We have Ann Bright on Zoom.
Yes, Indiana was a little late in coming to expand Medicaid to single adults.
Yeah.
And at least my feeling is they're doing what they can now to restrict it by adding work requirements and other paperwork requirements. Could you just make some comments about how you think the Medicaid expansion may have helped with these issues?
Sure, thank you for that. The Medicaid expansion helped tremendously. We very rarely see somebody without insurance now, where, 2015, a lot of the people that were coming in didn't have insurance, and the expansion of insurance navigators helping to the patient navigate the process of enrolling in Medicaid has really been helpful. During the healthcare emergency, a lot of those restrictions to Medicaid have been pulled back, and so people have had unrestricted access, and it's really allowed us to connect with people in a way that we've not been able to before. The state has been hearing from physicians like myself about the importance of people having and maintaining that access. And so, we're really hopeful that some of these restrictions will be rolled back. There was an initial restriction to where people with Medicaid could not receive telehealth services if they didn't have video capabilities. And a lot of physicians, including myself, spoke to how important it was for us to maintain access to our patients with Medicaid. And if anyone doesn't have access to video, it's probably our Medicaid population who doesn't have broadband, data plans, those sorts of things, or even a device to be able to connect. And so us being able to connect with them with audio only was really important. They heard us, reversed that, and allowed us to continue to see Medicaid patients audio only, which was really important. So the emergency order ends in April. Those paperwork requirements come back. We've been trying to communicate with our Medicaid patients the importance of turning those documents in. We do have some community health workers in the community that are trying to work with people to get those documents turned in, insurance navigators. So hopefully we're not going to see a fall off from that. But for the last few years, it's been like night and day what we've been able to do with our, our most vulnerable populations there.
Hello, I just have a question. Earlier you mentioned Scott County was the 3rd county out of 92. So I was wondering if you could tell us anything about the other 2 counties.
Yeah, one of the counties was, I think both of those counties actually, if I remember right, but I know one of them was a county that has a major penitentiary. Most of those cases were coming from the prison, and that was significant enough to make them number 1. And another community looks very similar to Scott County from a demographic group. So it's Fayette, I think was 1. I actually have the graph. Let me look. Yeah, Fayette was there. Hendricks and Park were the other 2. Those are the worst 4. I think Hendricks is where the penitentiary is, if I'm right. And then I'm not sure where Park is, honestly.
All right, one more question.
I have a question. Dr. Cooke, the Governor's Commission on Public Health has come out with a model, and that model is looking more at, rather than local control within the community with public health, there'll be more of a statewide control. And I just wonder if you have some thoughts or could give you how you view that, especially with what's happened in the past.
Sure. I will always advocate for local communities to have the lead. Again, one of our biggest successes was just listening to people and responding to the needs that they shared with us. There's no way for a centralized, whatever it is, group to know what's going on the ground in each community across the state. I mean, I would really want to see, local control over what services are offered, what grants are being passed down, because every community looks different. And an urban community and a rural community, you might assume that they have different needs, but oftentimes, depending on where they live within that urban community, a lot of the needs are the same. And that bias might lead you to enact different things in those 2 communities where maybe the same sort of programming would work, or vice versa. Maybe they look completely different, and doing a one size fits all doesn't work. So we really need to see what each community needs, what they're struggling with, what resources they already have, invest in those resources first, allow them to be stronger, more rooted, and then fill in around those community resources that are already there, so we don't accidentally, squash work that's already being done.
Well, thank you again, Dr. Cooke. This is we really appreciate it. We will be making a contribution to support Pets Alive. This is our quarterly charity that we will be making a donation. And thank you for your presentation. So So the next meeting, we will be in the Georgian Room on March 21st. Our guest will be Barbara Leninger from the Arthur Murray Dance Studio here in Bloomington with a presentation called The Best Job in the World Teaching Dance. So Tyler, if you'll bring up the 4-way test. So please join me. Oh. Of the things we think, say, or do, first, is it the truth?
The truth. Second, is it fair to all concerned? Third, will it build goodwill and better friendships?
Fifth,
Or
is it fun?
will it be beneficial to all concerned? Fifth, will it be happy?